Yo, what's up? It's your boy here, Sigaga, and I'm back with another video. Leo mkiona niko lab, but sijafika tu lab bure. Huku leo, huku ni ofisi yenyewe. Nimesema tu let me shoot for you guys this, ndo nitaonyesha kwa nini nimetaka kushoot hapa. So basically mtu unaendanga aje kwa lab because uanzange lab straight, unaona? Kwanza utakuja OPD, outpatient department, where utapatana na doctor ama clinician hapo. Atakuuliza maswali on how you are presenting, how you are feeling, utamueleza all those venye ma answers vile una feel. Mostly history taking ndio ina guiding the clinician or the doctor to make an appropriate diagnosis. Just the lab ina helping with the confirming the diagnosis. So with a good history you don't even need to go to the lab. With a good history you can just know what you are facing. So basically na tutakingi tena kukua ile ati lazima pia lab ipate kazi, si ndio? So after that patient amekuja pale, umepata history, ukaona kabisa yes this one let me send to the lab, atoe sample tupime. So what you does, unajaza the lab request form, of which after hapo unamtuma nayo anakuja lab. Akifika hapa anapatana na lab technician. Lab technician anaweza kama ni malaria for example, atataka blood. So either pierce the finger hapa ama anaweza toa from the vein. So ita depend na the lab. Kama ni test moja obvious, kama ni malaria peke yake pierce from the tip of the side of the tip of the finger, any finger. So after that atachukua, kama for example ni microscopy umeorder, for microscopy visualization use the glass slide. Unaona that glass slide, yes, pierce your blood and then I apply to the slide, of which atachukua some specimen pia apply on it and then I rinse it off, aache it dry. So ikisha dry, that is when ataichukua ipeleke kwa hii mnyama hapa inaitwa microscope huyo. So visualize through the microscope where atakuwa anatafuta the parasites za malaria. We have the Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, but the most common one are the Plasmodium falciparum. Unaona? So visualize through the microscope, he can be able to identify the Plasmodium species, which one ni gani. So from there ataandika back to the lab results yenye ulikuja nayo, of which akishaiandika anakutuma back to the OPD. Asa ukikuja OPD, that is when tutaamua sasa according to the parasites zenye zimeonekana, determine which drug to use to you. But mostly we categorize it as complicated and uncomplicated malaria. For the complicated malaria, patient atapresenting with other signs. For example, atakuja na hypoglycemia, hypothermia, atakuja na convulsion, atakuja na vomiting, yes, all those plus the headache, joint pains, yes. And then that now will guide us to itakuwa ni complicated malaria. Hapo the treatment tutatumia ni we'll admit the patient, yes, na hapo tutatumia Tesunet. Calculate according to the body weight. So tukipata ni uncomplicated, now there we have an option mbili ya treatment. We can either decide to use the AL medication or we can opt to use the artemether injection. Either one of them, the patient, depending on the affordability of the patient. If the patient is well off in the pocket wise, he can go for the artemether injection, which is a 3 days injection, once a day only. So we'll calculate also with the body weight and know the right amount of drugs that the patient needs. Then from there, we'll be able to administer. For the AL, we have it here as a sample. I don't know if you guys can see it. Yeah, that now is the AL that we normally prescribe to the patient. It comes up in a box like that, and it's normally 24 tablets inside. So now it will depend on the body weight. For example, if the patient is 5 to 14, there the patient will be able to take 1 tablet twice a day. You're getting me? So he'll be able to take morning and evening 1 tablet. If he's from 15 to 24 kg, he'll be able to take 2 tablets. If he's 24 to 34 kg, he'll be able to take 3 tablets. And if he's above 35 kg, he'll be able to take 4 tablets. So how is the patient supposed to take? You just don't say at the morning and evening. So if you have been given the AL, we'll give you the start dose there to see if you are able to tolerate the AL medication or you're not able to tolerate it. So once you have taken it and you have tolerated, now we'll count from there as the start dose. Then we'll tell you to take the next one after 8 hours. You're getting me? After 8 hours. Not that you take it in the morning and in the evening. No, you take it after 8 hours. Then the next day, now those are the 2 doses you have taken already. The next day it will be the 3rd dose. You take it the time that you started taking the first dose. If you started at yesterday at 8, you'll take it at 8. Then you wait for 24 hours, you take the 4th dose. You're getting me? Then the next day, the 3rd day, now you take it again the time you took the 1st and the 2nd dose. That if it was at 8, you take it at 8 again. Then you wait after 24 hours, you take the final dose. So if, for example, a baby was taking L1, is a maximum of 6 tablets the patient will use. If it's taking L2, the patient will take a maximum of 12 tablets. And if it's L3, the patient will take a maximum of 18 tablets. And if it's L4, the patient will take a maximum of 24 tablets. So L1 is 1 tablet, L2 is 2 tablets, L3 is 3 tablets, and L4 is 4 tablets. Then there is also this thing that they normally write it 4 times 2. Not everyone is learned. Some people might follow what you have written. For example, if you have written for them 4 times 2, they'll interpret it as 4 multiplied by 2. So he or she is supposed to take 8 at the start. At the same time, you might come to the clinic or the hospital and you find maybe the lab technician is not available today, or maybe there is no power. There might just be circumstances. Maybe the lab is not functioning that day. And the ministry, what it did, it said we don't need to treat just clinically. When for example, the lab, the microscopy is not available, they opted to give us this thing called an RDT, rapid diagnostic testing. So as you can see, this one I've already used it. I used it and it gave me a negative result. So as you can see, there's a line that has been drawn here that is showing it's negative. But if it could have drawn here and here, it could have been positive. But now if it could have only drawn here, that could be invalid. You did it the wrong way. So what we do, we basically put here our sample. Once we put here our sample and here we put our buffer. So that is all on the RDT, but on the RDT, I can't say that it's 100% accurate. Because, why can I say that? At times you might come, test the patient using the RDT. Then it gives you a negative results. Maybe it's saying the patient doesn't have malaria because it normally tests the P. falciparum, Plasmodium falciparum. So once you have tested and it has told you it's negative, and the patient, clinically, the patient is presenting with headache, vomiting, joint pains, and you can clearly testify that even the mother is telling you, or the patient, him or herself is telling you, I know this is malaria from how it has always been presenting. So what I can say, we can also treat it clinically, because there was a time it came negative. I opted to treat it clinically, so I gave the patient AL. So the patient responded well to treatment after the first day. The mother told me, yeah, my kid has responded well to treatment. So at the end of the day, I realized the RDT had told me it's negative, yet the patient was positive. So basically, it's not like I'm against the RDT, but I'm saying the best one is microscopy. If you can be able to do the microscopy, just do it. We normally do the RDT in case just the microscopy is not there. But if you do the RDT, it can be positive, sometimes it can be negative. So you just assess also the clinically and you can do what is available. Then also once you have also been able to be treated for malaria, you can do a confirmatory of checking up, following up with a microscopy also to rule out if the treatment worked. So you can also do a lab test again. You can prove if it's negative, then you're good to go. And then once you're home, the preventive measures you can do, you can at least make sure you clear the bushy compounds. You can also, if there is any stagnant water, you can clear it, or if it's not able to be cleared, you can apply oil on the water for it to prevent the breeding of the mosquito. And then also in the evening, you can ensure you dress long sleeved shirts or tops or blouses, and also trousers, and you can wear socks. You can cover most of their skins in the evening, that can be able, mosquito can be able to bite you through there. And also make sure you sleep on treated mosquito net, of which when you are going to sleep using it, ensure that when you have tucked in your net, ensure before you sleep you check if there is any mosquito within your net. If there is, you can make sure you kill them. That will prevent them. Once you have slept, there will be no mosquito at all. You know, people usually tuck their mosquito nets and they don't confirm if there is any mosquito that you have locked yourself together with it. So at the end of the day, you'll be wondering, why am I getting malaria and yet I sleep under treated mosquito nets? So make sure you confirm. And then if you are able to use the repellent, you can also be used. That will be a great way. So also, there's a previous video I'd done for you guys about the hookworm manifestation and the deworming using the albendazole. So there's a video I'll upload for you guys. You see it on how the hookworm's larvae it looks like if you don't deworm yourself. I was able to get a glimpse of it, and I thought, guys, let me show you how it looks like, so that next you can know the importance of deworming. Other than that, see you on the next episode.